morning, everyone. I topic was given to me with the history of spine deformity care, and I think that sort of mostly combined with the history of Scoliosis Research Society. So this is my disclosures. Uh, uh, so I, am, as you might know, I'm a firm believer of uh, really knowing the foundation and history of both, science and arts, in order to be competent to make some progress in the future. So we are basically looking at that, and I think my journey in the spine started in 1975, and over the past half a century, I've been uh, observing a lot of history on spine deformity and spine disorders care that has happened. So pretty much I sort of try to tell that story. In 1975, I did my fellowship with these four gentlemen. Dr. John Moe was the first uh, president of Scoliosis Research Society for 3 years, and he founded the society. And with his colleagues, I sort of learned how to um, uh, deal with the, uh, you know, kind of they all had the open mind and try to learn things as they uh, develop and innovate. Scoliosis Research Society was founded in 1966. Dr. Moe, who is in the middle here, had a course in uh, spinal deformity in 1965 in Minneapolis. And during that, people suggested that we should have a club. So they called it Scoliosis Club. And uh, then they decided to come in back in Minneapolis. And there were 37 people in that meeting. And there's 35 here and two missing members that we just recently had a sort of an article on that, I think, in spinal deformity. And they really got together, and uh, two of these members, Dr. Dave Levine here and Dr. Ron DeWalt, just happened to be there because their chiefs wasn't they were not able to attend, and therefore they're probably the youngest members that still with us and part of the founders of the Scoliosis Research Society. This is Dr. Blount. In 1976, I had the opportunity to go to Canada with him, and the name of Blount and is associated with the humanitarian award just our own Greg Mundis received in RSR's meeting this year. But I could actually stop here because in the 50th anniversary of Scoliosis Research Society in Minneapolis, we had an exhibition that really created a comprehensive historical timeline of spinal deformity evolution, along with the SRS role in developing those. And if you go to the SRS website, you can see virtually, you can see the uh, museum, which and the timeline. And the timeline is evolving even after 10 years after the 50th year anniversary. The historical committee sort of adds things and is kind of a living document. And I strongly recommend to go because it's all the details. You can download it. You can see by decade what things have happened in the field of spinal deformity. Also, there is a paper that we did a few years ago that probably you can see in the seminar of spine surgery that tells a little bit more about this history. So, but we go, trying to mix the SRS evolution and the spinal deformity. Um, we can just kind of go pre-SRS when the SRS was born, which I mentioned, and during the 60 years of SRS and what perhaps can happen in the future. Hippocrates, always credited as father of medicine, used the word of scoliosis, and he also used somehow bracing and casting in the treatment of, the oldest evidence of treatment of spinal deformity in his era. We know about hanging casts, about the uh, uh, Lemessier from Canada, did that. And we had this turnbuckle cast. You can see the turnbuckle cast was a cast that was put, and the patient was corrected uh, gradually with this turnbuckle. And this is not too old because as a resident in early 70s, 73 or so, that we were putting these casts. And of course, we had a significant, skin things, sores and so on. But once they get the correction, uh, and then operate it through that cast, I can imagine that how draping and cleaning this would be cumbersome. But during the cast, inside the cast, you can just do the operation. Before there was no metal or there was no implants to put, and uh, and uh, uh, and that's post-operatively. In Milwaukee, brace really uh, developed for care or holding the spine after surgery. It's a post-operative immobilization, but later became a tool for a non-operative treatment. And this was done by Blount and Schmidt. When you think about internal fixation, can't go through the detail, but there were really a different types of fixation, from wires to implants to rods throughout the 1880s to early 1900, and each had been reported in different uh, capacities. But the main sort of starting point for spine care was by Hips. In 1911, I think Hips reported spine fusion for tuberculosis, but not for scoliosis. But in a few years later, he did the first scoliosis surgery in 1914 and showed some cases at the orthopedic hospital in New York. Um, Now, during that era of early 50s, there were two sort of giants in either side of the coast. Cobb was on the East Coast, and Risser was on the West Coast. Cobb was doing surgeries with a variety of casts and different grafts, and sort of developed uh, sort of technique of some pseudarthrosis, but he was the one that really did the Cobb angle. And it was interesting during the second meeting of the Scoliosis Research Society. The whole meeting agenda was whether to use Cobb's method or Ferguson method, which was a different method, but finally decided to use Cobb. So that was from Cobb, but the other side, Risser, used the same type but different cast, within a table that was Risser table, and obviously the Risser um, sign of the pelvis. Um, John Moe, who was trying to bring these two groups together, actually helped to develop a scoliosis center at Gillette Children's Hospital, Gillette Crippled Children in St. Paul. And uh, he was a kind man. He was tough for everybody else, but for his junior guys were very open, and he was always listened, and obviously was the president of Scoliosis Research and founded a society. So his report, the first report was like 58 with something like neuromuscular patients, 14% pseudarthrosis. But he was the first one to recognize flat back caused by Harrington rod, because the Harrington rods were very straight, and he was not able to bring, curve it in lordosis, and the rods would rotate and actually became kyphotic. So he developed a square end hooks that you could put the square and then prevents rotation. And he was the one to really recognize that. But for a long time, this scoliosis really was only one uh, 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 direction, and there was really not much lateral. Even X-rays were taken. So this was the first recognition of sagittal uh, uh, alignment. This is an example of a patient, a 12-year-old, had a curve like this, 74 degrees, and was treated with a cast, those methods, no instrumentation. And this is like at the age of 17, which was pretty much maintained the fusion and alignment. And 25 years later, you can see still the alignment exists. So at that time, didn't really need, or at least, but it took a lot of effort to, put the cast on, every time after 3, 4 months, we changed the cast again. And we had perhaps 7, 8 cast changes and cast application pre-op and so on every night for the patients that's coming in, and for the next day preparation and so on. So it was a lot of time wasted, and obviously the patients were in bed for a long time. Until Paul Harrington came, the first sort of real change in the treatment, modern treatment of spine. It took him about 7 years to develop this one rod and 2 hooks. First, he had this convex, actually compression rod. Started with that, and then they developed the distraction rod on the concave side. And so he really, this is the convex side hooks, this threaded rods, and hooks coming to over the transverse processes. And this was under the facet and over the lamina. So these ratchets were giving the correction. I think I've mentioned before the book that Dogged Persistence that Mark Asher wrote, and really gave a great description of not only what Harrington did to treat the spine deformity, but also his character and the man he was. So I really recommend you to learn to read. I have one for fellows each year. So this is really a great read. Um, Luckey, Eduardo Luckey was the one that really developed a segmental fixation with wires, subliminal wires, because in Mexico, it was hard to, the heat was hard to have the cast on, and um, he trained with Drisser in Los Angeles, and ended up marrying his Risser's daughter. So he was actually was connected to Risser as well. Um, I remember in '76, I think he came to Scoliosis Research Society and gave his first paper, and he just used this blue uh, slides and with wires and so on. And people were saying at the intermission, oh, he's crazy. And but he actually started the segmental fixation and put them in no cast, no brace afterwards, and followed by Cottrell Debussy, who developed that were more uh, advanced rod, nerd rod and multiple hooks. And the first surgery was in 1983. And I think it was 1989. They were here in San Diego that they did the first surgery uh, in U.S. and then later on in different areas. And Harry Schafferberger, who just uh, passed, was the great uh, advocate of this technique in Miami. This is the example of a Cottrell Debussy technique. Oh, there are other things that's really associated with the care of spine. The wake-up test was first by Stagnara and developed, or at least described by anesthesiologists. But he had the wake-up test to make sure to prevent neurologic injuries. And then later on, the spinal cord monitoring, Les Nash sort of presented that first, and that how much has advanced to date. Pedicle screw obviously was the game changer for care and the correction of spine deformity. And these are people who had initially worked on that. This was through uh, the through the pedicle through the facet first, and I think the um, um, next this is the technique that Boucher's technique through the facade, and then through the pedicle, basically from Roy Camille from France, and then Arthur Steffi, who sort of popularized this pedicle screw in the United States. And you're probably aware of how difficult it was to get the approval from FDA. It first was used as bone screw, and the uh, attempt to clear it through FDA was not very successful, and there was a lot of legal issues with the pedicle screw. This is Steffi's plate, and use the screws, pedicle screws, and a plate. Suk in Korea really pushed the thoracic pedicle screw, and this is an example of that. And Harm and Jasinski, they did a transforaminal, TLIF, and developed that and popularized that. So these techniques gradually became routine in different places. Osteotomies started with Smith Peterson and Thomason, PSOs, and as we moved forward, all of these techniques were included in the armamentarium of the spine surgery, and each sort of used the previous experience and added some more to have what you have today. Anterior spine actually came from Hong Kong and popularized by Hudson for TB, and then by Dwyer, who made the first instrumentation like a cable to put it in the convex side of the curve and try uh, to correct the scoliosis. And Zilke, which was a great surgeon, German surgeon, and he made this cable as a solid rod. And this is a way, for instance, in this Linky 5 curve, you have shorter fusion and a better correction of scoliosis. That was his contribution. Thoracoscopic surgery was really something that came up. Peter Newton here had a lot of to do with that and developed very nice techniques and was able to do the release anteriorly through the thoracoscopic approach. And this is an example of a patient that had the anterior release by thoracoscopic surgery and the posterior instrumentation, which I think was very promising at the beginning for this. However, again, Peter's work, after a follow-up of long follow-up, found that probably some of these, especially the thoracic curves, can be treated by posterior instrumentation with minimal disability. So the next thing was, how can we get motion? And that brought, again, studies here by Newton and others to show the tethering might be useful for creating or at least maintaining motion of the thoracic spine, which again, that's something that is not is falling from interest, but mainly because the spinal motion is more in the lumbar spine. So I think the cases that the combined fusion and tethering of the lumbar spine is becoming, so it's evolving, and we don't know where it's going to go, but that's the new thing there. That's the start. So just to tell you, this is mostly for decades, the Scoliosis Research Society was really focusing on AIS. And the adult and early onset little kids were ignored. I remember when the first adult sort of paper was presented, it was why we should operate on adult scoliosis, and that was by Kostevig and others. But now you can see that how many papers in the SRS is in adult, and one of the reasons for that is the ISSG, for instance. And I wanted to sort of give you a little clip here for what the ISSG was and how San Diego was contributing. These are 4 men that developed the Isola technique and sent an IDE to FDA, but FDA really was not And it was not successful because because of all the legal things and so on. And the screw was used as a bone screw for a while, and that really caused this whole legal issues. But this was Isola group forming people: Mark Asher, scripting, Walt Stricken, Carlson, who's an engineer, and Jake Heineck, who is really a great surgeon. Uh, and uh, and this was the group that sort of helped to push this forward as far as the development and education. Um, Early experience uh, was reinforcing what the uh, system was doing and gradually was improving. And uh, and I think it was focusing on education was the great uh, uh, thing that the Isola group did. These are slides from Doug Burton that presented the history of ISSG in New York a couple of years ago. So the first Isola study group was in 1994, and I think after that we had like 54 seminars, or not seminar, but study group meetings uh, after that. And in 2005, the name was changed to ISSG, and um, and then the first sort of uh, the focus changed more to research, and I think it was in 2008 the combined Harlem Study Group and ISSG meeting was done in Beaver Creek, and then there was some um, uh, Jay Bess, who was at the time with us here in San Diego, was given the lead for the group, and since then they've done, as you know, a great um, uh, job of including all the members and sites that you can see here, and took off to the position is now, and this is like uh, 400, there's even more. This was 2 years ago, and about a few thousand citations every year. So it was a great progress. And the little kids, I think first uh, uh, device was Vector, which was a for thoracic insufficiency syndrome, and then Bob Campbell, who developed this, took him 17 years to pass that through FDA. So that was another device that really was a historical and he really was champion that. Growing dual rods and growing rods were done, with many tutorials here in San Diego, and as well as MCGR. That was a uh, timeline for that, and was finally approved in 2014. And this is a magnetic device, and pretty much our foundation, which incorporated in 2004, supported growing spine-related research, and tutorials were here from 2000 to 2006, and then was uh, led to develop to the first meeting of ICOS in 2007, and this year, next week, we are going for the 19, and the next year in 2020, it would be in San Diego, and that was probably one of the reasons that research and development of new methods for care for small children happened. And so you can see after 2007, when the first AKS was there, how many papers and research studies have been published. Then growing spine study group that was started in one side with mostly growing rods and so on, and children's spine, which was the vector group. We joined. We joined and made the started the Pediatric Spine Foundation that now has like almost 12,000 cases worldwide, uh, and moving forward with many research studies in early onset scoliosis. So it's not just the implants. It's many milestones in anesthesia, antibiotics, imaging. It's a great. You can see that now with, for instance, EOS and the 3D imaging of the spine. You can understand the pathology much better than before we did, 2D or 1D images. Bone graft fusion, biologic instrumentation, obviously, spinal cord monitoring. But the new surgical technique will come. The motion preservation is on the go. Some successful, some not as much. Navigation, MIS, use of AI. I think all these things are pretty much on the move, and I'm sure in your era you will see much more of development, exponentially. So I think that is basically what we have to expect in the future. But I think the main thing here is someday, we may be able to prevent deformity, and always prevention is better than cure. And children can get a scoliosis pill and cure the scoliosis, or it doesn't really happen. So we are hoping that we're not requires all of this technology. But anyway, what the technology that you'll use should not be a triumph of technology over principle. And always remember, first, do no harm. Thank you.
Any questions? Keep track all the study groups, huh? Yeah, seriously.
It's hard to give the whole history in half hour, but hopefully we have, at least with our fellows, we can have more discussions of the details. And I think what I really encourage is to go to SRS website and look at the things that are there, the videos and their abstracts of from day one, for 60 years. And you can see the trends. You can see things that became successful and the things that fell out of. It's just give you an idea of jumping on the bandwagon sometimes doesn't help, but how and why some are successful and some fail. So hope that you can do that.
Deal. Thank you. Thank you. All right. Thanks for getting up early.
Thank you very much. Take care.
See you on the other side.
Behrooz, Brad Courier here. I just wanted to say thank you very much for that incredible talk. That was really beautiful. I cannot imagine trying to give such a talk in such little amount of time, and the way you humbly downplayed your immense role in all of this is also admirable. Thank you so much. That was really a lovely talk.
It's so great to hear you, Brad. I hope that we can see you in person soon. Thank you.
Thank you. Thank you so much.
Thank you for your comment. Thank you very much. Bye-bye.
Bye.